Hello, and welcome to the Inside Scope, a podcast from Lakeland Regional Health, where we share insights from experts providing award-winning care right here in our community. I'm Dr. Daniel Haight, President of Community Health at LRH, and I also have the privilege of hosting this podcast. With us today is Dr. Zachary Boucher, Assistant Professor of Surgery at LRH. He's a graduate of the University of Florida and attended the University of South Florida for his general surgery residency. The Lakeland Regional community has benefited from his skills and services for over 5 years, and his practice focuses on robotic surgery with a special interest in hernia repairs of many different types. And I think that's where we're going to probably start today, is that to me, the word hernia can mean so many different things. And it's probably because it's a generic term, right? It's for a part of the body that's moved from its original location. But tell me, what are some of the hernias out there, and what is a hernia?
Yeah, I think that's a super great example of what they are. It's like something that's not supposed to be another place, right? So think of a hernia as like a hole somewhere, and through that hole, something protrudes, right? So the most common types are belly button and groin, right? So guys, probably 1 in 5 guys is going to have a groin hernia in their life. It's a super common thing. There's over 1 million hernia surgeries in the US annually, which is a really big number. And so the groin hernias mostly happen because testicles in men actually start in the belly when you're a fetus growing, and they descend through your groin canal, and it kind of burrows this tunnel through which groin hernias are a natural point.
And that tunnel closes off.
For most people, yeah.
It should, but sometimes it doesn't.
Right. And then through like the stress of life, whether it's, a lot of weight gain, a very heavy lifting job. Actually, fun fact, the highest thing you can do for increasing your abdominal pressure in this world is skydiving when you land. That pressure really puts a lot of pressure on your groin and your abdominal wall. So, fun fact. One
of those side effects of that. But how do I know that I have a hernia? Because I'm also, one of the things I find exciting is to know in medicine, don't always focus that it's got to be that. It could be other things. So how do you know you have a hernia?
Yeah, so the most common differential, we would say, different things it could be when people come to clinic. So hernias, number one, it could be a soft tissue mass, like a lipoma in the abdominal wall, like a benign fatty lump in your abdominal wall. And then we actually get rectus diastasis consults a lot for thinking things are hernias. Rectus diastasis is basically where your ab muscles kind of separate to the side over time.
Because you have a left muscle and a right muscle.
Yeah, that's the sick pack muscles. Yeah.
Yeah, and so sometimes they separate. The left and the right have a little separation to them, like too much.
Yeah, we think anything bigger than 2 centimeters is pathologic rectus diastasis, meaning like when you do a sit-up, that tendon isn't strong enough and your abdominal wall just bulges out. And it's a very common reason for lots of people, including other doctors, to think, this is a hernia when it's really not. That's something that gets fixed during like a tummy tuck or a cosmetic procedure, but it's not paid for insurance coverage in the United States.
We're all built differently with that.
And then, for rectus diastasis too, it's one of those things where it's uncomfortable to some people, but a lot of people are reassured knowing it's not something that's going to become like some emergency at any point, and something you can certainly get better with exercise over time.
Can you have a hernia through where you had surgery a long time ago?
Yeah, that's actually a super common reason to have a hernia. So we think whenever you make an incision through anything, skin, muscle, it never grows, it never heals back together at anything more than 85% strength of what it was before. So it's never better than the way you were born, unfortunately. And so it's a little bit weaker because of that, and it's a super common reason to have a hernia.
So that hernia is part of the body has sort of gone out, or has sort of left the belly and is starting to come out. And I often heard people calling it a bulge, but when should I start to worry about that or ask questions?
I think a bulge is a perfect time to start wondering about it, right? So a lot of times, especially in groin situations, we get referrals for pain without a bulge. And those are always tricky because a lot of times the groin has a bunch of reasons to have pain without a bulge, right? Like a lot of muscles insert onto your inguinal ligament, a lot of adductor muscles that help your legs squeeze together. A lot of times it's an adductor tendon tear that we get as a hernia referral, and it's really not. But a bulge is really a good sign.
What I really liked in some of the previous conversations we had here was the communication between primary care and surgery. So I think you probably have patients just contacting you directly. Do you get referrals from primary care doctors, say at Lakeland Regional, that might be seeing a patient and they're concerned that it might be a hernia?
All the time. I'd probably say that's 60 or so % of the people we see are referrals from primary care doctors. And even if it's not a slam dunk diagnosis, like we appreciate that, right? So like even if it's a kind of sort of maybe, not sure if it's a hernia situation, we think we're the perfect people to have that like really detailed physical exam and conversation. And if you need imaging after that, like an ultrasound or a CT scan, like we're happy to be the ones to decide if you need that.
Because I know right now you see that a person might think they have a hernia. They might end up communicating, of course, with their primary care doctor, but then they're maybe just walking right into urgent care. And so with all the different locations of urgent care, they might find out that right there, is that a place where sometimes these hernias are diagnosed?
Right. And we have very easy communication with like our Lakeland Regional Health urgent care centers. To me, they'll message me and say, hey, I have this person right now in urgent care. We think they have a hernia. Can they come see you next week? So great. That's an awesome way to keep someone out of the ER, get some peace of mind, and quick follow-up.
Well, are the hernias we're talking about, are they dangerous? Or what are the red flags or things that I'd say, wait, this is one of the things that are urgent? What would be?
Right. So I would say the red flags for hernias are if you have a bulge that usually you can push back in, and then one day it hurts a lot more, you can't push it back in, and it's red and swollen. Those are pretty big 3 red flags that you may need to go to urgent care to get it evaluated.
So red and swollen. And so hernias can come and go. You can sometimes push them back in.
Right.
But you're saying you can't push it back in.
Right.
And does it go beyond that with the pain, or do you get fever or vomiting or things like that?
So if you have intestine in your hernia, then you're sort of like blocked up. If you're plumbing like from one end to the other and you're blocked up somewhere in the middle, things are going to back up and start throwing up. So yeah, throwing up is a sign of that.
Then that's where you get that care right away. What are some of the things that do you try to do first when you think it's not the serious hernias? Or is there anything that you're trying to do with the hernias?
If we know that's not a serious problem, then we usually have time on our side, right? And that's one message I would like to sort of get out there, is that the overwhelming majority of hernias are not an emergency, right? You can have them.
As long as you're not having severe pain, fever, and that, so you can sort of get a plan in place. I know when everybody wants to succeed during surgery, and I think it's your connection with the primary care that gets people ready for surgery. What are some things you really want to have your patients, what kind of questions do you want them to ask? What matters most to them? But what do you want to do if you know you have a little time before possibly doing surgery? Yeah,
so some things before surgery that you can like really optimize yourself and set yourself up for one good hernia surgery and never need another one and like our primary care doctors are excellent at getting patients as healthy as they can possibly be, which is really the message before any surgery, is you want to be as good as you can be before surgery.
You want your breathing doing well, you want your sugar levels doing well.
Diabetes control, weight loss to an appropriate amount, medical like problems as optimized as they can be. Like if something is actively getting fixed, you don't want to do more or less an elective surgery while something else is getting fixed.
I like how you and your team, you ask the patients and you say, what matters most to you? When somebody's thinking they're got a hernia, it's going to probably need to be fixed, what's really going through their head and maybe the family's head about what's most important to them? And how do you address that and find out about it?
Yeah, so when first evaluating somebody with a hernia, like you said, you say, what are your goals with getting this fixed, right? Do you just want that bulge to go away, which is a totally fine reason, right? Like you have a hernia, can totally fix it, make that bulge
like I said,
away.
You can have a hernia right around your belly button. You can have hernias down near your groin. For men, they can have hernias down in the scrotum. You can have different hernias going through an old surgery. And so, yes, if they got the red flags, and you also want to get these repaired for the appearance. So what are some things folks are worried about that they want? They said, well, I want this surgery, but I want to know. What are good questions a patient could ask?
So a lot of people are told once they have a hernia, you can't be active at all until you get it fixed. Like they worry that they're going to make it pop out even more, potentially cause it to rupture and things like that. And I disagree with that sternly. I think you should continue to live as active lifestyle as you possibly can when you have one, up to the point where you get it fixed. Because when you get it fixed, you have to wait a few weeks afterwards before you lift heavy. And so leading up to that, if you make the muscle strong and the tendon strong, it sets you up for success.
Well, I like what you said earlier. As long as you know the red flags, if you're not clued in to what to be on the lookout for or what exactly this is, I could see the danger in that. But when you're connecting with your physician and the care team, and you know, hey, this is what to look out for while we're waiting for surgery or even deciding we need it.
Right.
And then you're getting them tuned up, getting a person ready to go, getting some of the other muscles stronger.
Right.
Tell me a little bit about the surgery, the different ways of doing the surgeries.
Yeah, so hernia surgery is really transforming into mostly a robotic practice in most of America, meaning like robotic surgery is being used a lot for hernia surgery.
And when you say robot, you're 100% in control with the procedure.
100%. Whatever our hands are doing on the outside, the inside instruments are doing in the patient, which is awesome because we can make little tiny movements and do really big surgeries through little tiny cuts.
So robotic surgery is like an extension of your expertise. You're able to take the machinery and basically it can do and see more that you're able to gain an advantage with that.
Yeah, there's a ton of advantages to it. If I had a hernia, I would 100% look for someone who did robotic surgery to fix it.
Oh, excellent. And then seeing that, what are some of the benefits then of the robotic surgery?
Really, it's really how fast you return to work and activities, your pain control afterwards. We very rarely use any narcotics after these surgeries. It's almost just basically a Tylenol and ibuprofen.
Narcotics can be constipating, right? So you don't want to have that.
Right.
So with robotic surgery, the pain control is a lot better.
Pain control is better. You leave the hospital faster. You return to work faster.
The other part I like is how you really dive into not the person is having a hernia, but it's an entire person. They have their own uniqueness. And so that might make their hernia different, like more complicated. How do you handle the really complex ones? Because in the past, folks had to travel around to get a unique or complex hernia fixed. Are you handling then the more complex cases? Right.
We are very motivated and skilled with the surgeons that we have here. It's not just me. It's a lot of surgeons at Lakeland Regional who are like excellent at what they do here. And we don't see any reason to leave Lakeland and Polk County to have any hernia surgery for any reason. And so we have a team behind us. It's not just us. If it was just us, we couldn't do it. It's the nurses. It's the recovery team. It's the ICU when we need it. It's a whole team of people at our office, schedulers, people in the OR. Everybody is wonderful, and it's all these people together that make this experience just so fluid and seamless.
Well, stopping by your Grasslands office right there on Hardin and Edgewood, you're just the team that not only welcome you to get going to sort of head down that journey to finding out what's wrong, but they had exactly what to do after surgery. They knew what advice to be giving because it helps to hear it from you, hear it from your team. And then you have the folks you mentioned at the hospital, is this a kind of surgery that typically you stay in the hospital or you have the surgery and you get, again, more education and then go home? How does that work?
So prior to robotics, most people were staying for some of these surgeries in the hospital for a few days. And now that we have it, the overwhelming majority of people go home the exact same day. It's an outpatient surgery.
Okay. And what about the activities? Well, let's start first with the showering. How soon after the surgery can you bathe and shower?
So I say shower same day, and I say 2 weeks for underwater submersion, but that's actually a total surgeon opinion about those things. There's no hard line about like, this is for sure the right way to do it. And the same thing with post-operative lifting instructions. Like mine is nothing heavier than 40 pounds for 4 weeks. Basically, I don't want you to flex your abs for 2 weeks, but everybody has a different number and a different length of time.
Well, I know what 40 pounds weighs like since I just went to the airport. That's like, okay, that apparently I went over. So having to unpack in the middle of the airport.
Yeah, putting a hair straightener in your backpack.
Everything, getting that all set up. So the lifting is for the couple of weeks to take it easy. When is the usual follow-up coming back?
2 weeks.
2 weeks.
Yeah.
Now, because a hernia is part of the body moving to a spot that it shouldn't be through a hole, I've heard that you can cover this hole up to make it a little stronger with mesh. Right. What are some of what's the issue with the mesh, and how does that benefit? How does that change the hernia surgery, or is it just common to use?
Yeah, I think talking about mesh is super important because if I was a patient, I would ask about it too.
That's key. Asking your surgeon about that question.
I think almost every visit we talk about it, which is totally appropriate, I think. And so mesh used to get a bad reputation back in the day because we thought the thicker the better. And now we've since learned that you can make it very porous. It's kind of like a screen enclosure. Like if you walk up to a screen enclosure, you cut a little piece out. That's essentially the material that we're using. And so the idea with it is that if you're laying like a concrete foundation to a home and you just do concrete slab with no rebar, that looks fine initially. But then over years where you load different bearing of weight on it, it'll crumble and crack over time. So it's essentially a rebar analogy. We use it because it decreases the chance that your hernia comes back.
Oh, excellent. And then it was really good that you pointed out, what if I do nothing? You have to look out for the red flags. You should only do that with advice of a physician. And then with the surgery, trying to get through the recovery. What are some of the other things that you think are important when when it comes to hernias?
Well, one thing is that like surgery like isn't for everybody, right? Like some patients, it's not appropriate. It is best to just watch it. And so that's our job to have that conversation, right? I'm happy. Like we have a ton of conversations in clinic that don't lead to surgery. And I love that because like you said, you do what's best for the person, not best for the hernia. And the second thing is, kind of a different realm of hernias. It's called a hiatal hernia. And that's when part of the stomach goes from where it's normally supposed to be in the belly up into the chest.
Yeah, because you've got your chest, and then you have your diaphragm, and then you have your stomach under the diaphragm. So the hiatal hernia is the stomach actually going up into the chest.
Right.
And I imagine since the stomach has a lot of acid, that might cause more acid to be leaking back and forth.
There really are two major symptoms to that, and acid reflux, even like being on maximum, all the medicines you can take for acid reflux, it just still isn't making it better. And two, we call it dysphagia or difficulty swallowing. So like food goes down and gets stuck in that hernia, and then you regurgitate it back up. And so those are the two main symptoms and why we like fixing those.
When I was a medical student, I would start to learn the different parts of the examination. And that was when I really didn't know a lot of medicine. But I always remember the turn your head and cough from television.
Right.
And I thought, well, why do you have to turn your head and cough? Is there something that does to change the exam? And why do you turn your head and cough?
Yeah, there's nothing special about the head position. It's mostly so the surgeon doesn't get coughed on. Besides that, you can put your head anywhere and cough.
But the key care is that the coughing. That's the real message.
It's increasing your abdominal pressure. That's just the easiest way we can verbalize how to do it.
So you bear down, and when you cough, you bear down, and the hernia could get worse.
Exactly.
And often the patient, they already know that. I mean, they sort of know they are having a bowel movement, or they're straining, or like you mentioned, even the parachuting, that strain sends the hernia and causes it to move out.
Right. Yeah.
I guess the worry is maybe big hernias tend to go out and come back in, but the small hernias can go out and get stuck.
Yeah, that's a good point. So we call the wide mouth hernias. Like if the actual hole in your abdominal wall is this wide, stuff's going to come in and out freely, and those are less likely
it
to
might
become
look
an emergency.
bad. It might see something like cosmetically you'd want it changed, but
the smaller ones that are small enough for things to get in but not come out very well, those are the ones that are a little bit more risky.
Yeah, and that's what I had learned in medical school. I guess when they come out and they can get irritated and inflamed, if they start to swell just a tiny bit, they can't go back in. Wow. So that's going to be where the pain, the nausea, the vomiting
100%
starts. Okay, that's key to look out that. And I'll always probably remember to turn your head and cough. So we'll remember that.
It's a classic line.
Yep, excellent. It's amazing just what you can pick up on television. You hear about on one show it might be a brain herniation where that's like life-threatening, and there might be a disc herniation in your back, and then you got this hiatal hernia, and then the hernias that are the intestines moving in different directions. It's so helpful to be able to sort of make it clear, because it's easy to, I guess, look it up on the internet and then misunderstand that what you found on the internet doesn't necessarily apply to you, because there are so many different causes of hernias.
Yeah, you're right. It's a super common word, and almost every body cavity has a hernia associated with it. So it's certainly hard to keep up.
Do the hernias we've been talking about, the hiatal hernia, the hernias that are occurring, run in the family at all?
We don't have great evidence for that, but we have sort of some fringe, like new evidence coming out that it does. It is affected by how much collagen you have in your tissues. Collagen meaning like how much stress some of your tissue can take before breaking. So how bendable are your tendons, and so people with less collagen have less bend, and so things break instead of bend. So we're learning a little bit about that, but we don't have hard evidence yet.
Well, excellent. I think the best take-home message was to say, if you're having any kind of discomfort or bulge or problems that you have a concern over, get to your primary care doctor. If you know it's a hernia, contact you directly. Your office is there at the Grasslands office in Hardin.
They're the best. Yeah.
Dr. Boucher, your team is also just fantastic, both at the clinic and in the operating rooms and in the recoveries. After that, can a hernia come back, or can a person get a second hernia?
Yeah, unfortunately, they can come back, depending on the body part and the size. We think around like 5 to 8% chance of the time they come back. But really, to set yourself up for success is do the right operation on the right patient at the right time, and it takes a whole village coming together to make sure that happens.
And I think you pointed out the thing about the complex hernias, because everyone's unique. I can imagine if you've had multiple surgeries on your belly, or you had a car crash as a youth and it changed your anatomy, and that makes your future hernia a little more complicated, and then you throw in some diabetes or other issues. Thank you for taking care of the whole person. I mean, that's what I think your team has really done a great job at.
I'm super blessed to be working with people both in the hospital and the clinic who are just tremendous and really love what they do, and you take really good care of people.
And it's located right here in Lakeland, so I appreciate all that you do and what Lakeland Regional Health is doing. Well, thanks a lot. I appreciate all the information. That's covered a lot of information, and have you back again, because I think there's so many things in surgery that it's a mystery, and we want to solve the mystery and have folks feel comfortable with that.
Yeah, awesome. Thanks for the conversation.
Great, thank you.